a GI cancer. And in that sort of instance, you've got to be able to figure out whether they're actually getting chronic bleeding and that's causing iron deficiency, or whether this is just an anemia of chronic disease as well. Lead poisoning, this is more OC health, but if it's more than 80 milligrams per deciliter, you're at risk of toxicity, typically due to occupational exposure, and that's all I'm going to say about it. Normocytic anemias, I'm going to talk separately about hemolytic, infiltrative, and bleeding hemorrhagic disorders, renal failure, and anemia of chronic disease. But macrocytic, we're going to move on to, so that can be divided as megaloblastic or non-megaloblastic. So megaloblastic typically features hypersegmented neutrophils due to B12 or folate deficiency, and non-megaloblastic could be due to any of the other causes, typically due to poor cell membrane structure. So megaloblastic, we've pretty much mentioned all the main stuff. Just with the vitamin B12 deficiency, make sure you also look for other signs like peripheral neuropathy, altered gait, or if they have tummy pain, because they could have pernicious anemia or Crohn's disease of the terminal ileum. And this is what a hypersegmented neutrophil looks like. And notice that this red blood cell is absolutely massive. The reason why I popped this in is just to remind you that know where different things are absorbed within the gastrointestinal tract. So duodenum, we get iron absorption, jejunum, we get folate absorption, and ileum, we get vitamin B12 absorption. So someone who presents with celiac disease, that typically affects the duodenum, so they present with iron deficiency anemia. Whereas Crohn's disease tends to affect the ileum, so they will present with vitamin B12 deficiency or a megaloblastic anemia. Make sense? So aplastic anemia is when they get destruction of hematopoietic stem cells within the bone marrow, and the most common causes are acquired, so something like chloramphenicol use, organic solvents, once again, here's OC health, and parvovirus B19 or slapped cheek. So the main thing I'm going to mention here is that they end up with pancytopenia, so they get bleeding, bruising, they'll get recurrent infections, and obviously fatigue because they're anemic as well. So you diagnose this via bone marrow biopsy. So notice how with this bone marrow biopsy, there's some cells here, and this is what normally the bone marrow should look like everywhere, so the cells that are here, but we can see that all of this is empty space, and that's because this is aplastic anemia. Make sense? Cool. Hemoglobinopathies. Okay, so we'll start off with thalassemia. I'll actually skip this and go straight here. So we have hemoglobin that's made up of alpha and beta chains, and depending on whether you're a baby or you're an adult, the type of hemoglobin you have will change. So when in the womb, you have alpha and gamma chains, and so most of your hemoglobin is actually fetal hemoglobin, that is A2 gamma 2. But as you are born and become an adult, this switches over to hemoglobin A, which is the normal hemoglobin with alpha chains and beta chains. We might also have some hemoglobin A2, which is A2 delta 2, and that's because we have some delta hanging around during adulthood as well. These are the different chains that the hemoglobin is composed of. So notice that if you have like an alpha thalassemia, you won't be able to use the alpha chains anymore. So you might produce something like hemoglobin H, which is beta 2. Or if you have beta thalassemia, you might not use the beta chains, and you might make something like alpha 2 delta 2. So your hemoglobin A2 levels would be higher than what you'd expect them to be. So yep, cool. So epi alpha affects Asians and Africans, but beta affects Mediterraneans. And the primary pathology here is abnormal alpha or beta genes. Signs and symptoms can be described as vascular, hepatosplenomegaly, and hemochromatosis. The hemochromatosis is from recurrent transfusion, so they end up getting a lot of iron, even though they're not iron deficient. So that's just that summarized in there. So types, so we have beta thal minor, which is just a single beta gene defect. Often these patients are asymptomatic, but they might have some microcytosis and basophilic stippling on their blood film. Might have a slightly increased hemoglobin A2. Yes. Oh, sorry, thank you. Oh, sorry to everyone online. Apologies. Okay, there we go. So beta thal major, on the other hand, is when both beta genes are affected, and that's when they get the significant anemia, vascular symptoms, hepatosplenomegaly, and hemochromatosis from recurrent transfusions. And this time on electrophoresis, we'll see a marked increase in hemoglobin A2 and this increase in hemoglobin F as well, which is the alpha 2, gamma 2 one, the fetal one. Yep. Management, lifelong transfusions, and iron chelation. Alpha thalassemia is obviously alpha genes that are affected, and if it's just 1 or 2 genes affected, they might be asymptomatic and not noticed, but if it's 3 genes affected, that's when they'll get hemoglobin H disease. So hemoglobin that manifests as reduced MCV, reduced hemoglobin and splenomegaly, and obviously a lot of fatigue. And then there's hemoglobin Bart's disease, which is when they don't have any alphas, and that's incompatible with life. So fetal death in utero. Diagnosis, the main thing you want to do is obviously a peripheral blood smear, and you want to do hemoglobin electrophoresis to see what type of hemoglobin they actually have. So this is what basophilic stippling might look like. It's pretty much just red blood cells with lots of little blue dots in it. And we can see a nucleated red blood cell here as well. And this is what beta thal might look like. So we can see that there's cells of many different types, many different shapes. So that's an isocytosis, and obviously some teardrop cells and cells that obviously look very abnormal. They're often called jigsaw cells as well because they look like jigsaw puzzle pieces. And this is the hair on end appearance that you get with the X-ray for beta thalassemia. Hereditary spherocytosis is when you get circular red blood cells due to some mutations in the spectrin proteins that make up the red blood cell membrane. So cells lose their central pallor, and often they end up with splenomegaly, so you might need to remove the spleen. So that's what they look like. They're just red circles on a blood film. Sickle cell disease is when there's a problem with the beta globin gene, and so they end up producing these kind of sickled cells that is also known as hemoglobin S. The prominent feature about these is that they polymerize when deoxygenated, and in their sickled stage, they have reduced elasticity and occlude vasculature, so that disrupts their circulation and leads to tissue infarction. So you need to do hemoglobin electrophoresis, preferably with a sickle cell prep. So this is just referring to the pathophysiology that you can read in your own time. But I think what's more important is the clinical presentation. So they might have something called a splenic sequestration crisis. So that's when they get a very large spleen, and they might present with anemia, hypertension, and reticulocytosis. Vaso-occlusive events as well, so things like recurrent episodes of severe pain or priapism, more common in children and teenagers, and chronic features like chronic pain, hemolytic anemia, and gallstones. And the main thing to point out in here is that some of the complications include functional asplenia. That's probably the main one. So they have to have their spleen removed. And this is what a sickled cell might look like. It literally looks like a sickle. And here's another picture showing more sickled cells. Does that make sense? Yep. So the way you want to manage this, avoid triggers, and you might give them something called hydroxyurea, and also immunize them and give them prophylactic antibiotics if their spleen is non-functional. And curative therapy, pretty much give them a bone marrow transplant. But if they're in acute crisis, do your doctor's ABCD, give them thromboembolic prophylaxis and something called exchange transfusion or erythrocytophoresis. This is unlikely to come up in an OSCE, but I guess they can chuck it in as like a multiple choice. Hemolytic anemia, there's many, many different types. The ones that you want to know are highlighted in red here, and some of these we've already covered because they're hemoglobinopathies as well. So clinical presentation, they'll obviously have features of anemia, but they might also have hemoglobinuria as well this time. Ask about autoimmune disorders and any medications they might be taking because they can precipitate hemolytic anemia. And on examination, jaundice is a big factor because they have unconjugated bilirubin around. They might also have hepatic failure or enlargement of the liver or spleen. It's important to know what a hemolytic screen is, and these are the things you're testing for in a hemolytic screen. So increased reticulocyte count, increased bilirubin, increased LDH, but a reduced haptoglobin. A positive DAT test indicates an autoimmune cause of the hemolytic anemia, and you can do a peripheral blood smear to see what kind of cells are present because that might tell you about the etiology of the anemia. G6PD deficiency refers to deficiency in one of the enzymes that helps metabolize reactive oxygen species. So obviously if you don't have this enzyme, these reactive oxygen species build up and they end up destroying the red blood cells because they're toxic to them. So it's usually causes an episodic hemolysis. So it might be triggered by things like drugs or infections or foods, particularly fava beans. And you can do a G6PD assay or a blood film. Blood film is generally the one that Monash tends to go with, and you can see Heinz body and white cells. Yep, cool. So this is what Heinz bodies might look like. They're kind of little blue things within the red blood cell, and this is what a white cell looks like. And these are Heinz bodies again. Autoimmune hemolytic anemia can be warm or cold. Pretty much if it's warm, they get the hemolytic anemia when the temperature rises above 37 degrees Celsius. It's a bit weird. And it's secondary to lymphoproliferative disorders like CLL or Hodgkin's lymphoma, which we'll talk about. And a cold hemolytic anemia is when the temperature is less than 37. One of the doctors in Bendigo thought I had a cold hemolytic anemia because I get like a rash when it's cold. So, but I don't think that's how these patients present. But yeah, so these patients, interestingly enough, will go yellow when it's cold. So it often occurs after an EBV infection. So this is how you might differentiate between the two, but what I've mentioned in the past slide is pretty much like enough to figure it out from the stem. One thing I forgot to mention is that warm typically occurs due to IgG and cold due to IgM. That's the type of antibody that you're producing. Bleeding disorders. Okay, so firstly, you want to figure out whether this is a primary disorder or a secondary disorder. And by that, I mean, is it a platelet issue or is it a coagulation factor issue? If it's platelet, it's going to be immediate excessive bleeding that's generally superficial, so things like nosebleed or bleeding or bruising on the skin. Whereas if it's secondary or a coagulation problem, it's going to be delayed bleeding, and they might bleed into things like the joints. So if you do have someone that presents with what appears to be primary hemostatic bleeding, figure out whether this is a platelet issue, a von Willebrand disease issue, or a vascular issue. So ITP is isolated reduction in platelets in the absence of any identifiable cause seen in females. Often occurs after a viral infection, and they get cutaneous bleeding and gum bleeding. But importantly, they don't have any hepatomegaly or splenomegaly. If they do have these features, then that effectively rules out ITP as a diagnosis. So it's considered a diagnosis of exclusion, but you might do an FBE that reveals an isolated thrombocytopenia. Management is largely self-limiting, but you might give them some steroids if they really need it. Von Willebrand's disease is reduced quality or quantity of von Willebrand factor, and obviously that's involved with initiating, it's part of both the platelet aggregation, but also part of the coagulation cascade. So because of this, they might have features of both primary and secondary hemostasis as part of their presentation. Because factor VIII lives with von Willebrand factor, when you measure factor VIII levels, those might also be low. So diagnosis, you want to do FBE, your coagulation studies, von Willebrand factor analysis, and factor VIII levels. And you can give them desmopressin to manage the factor VIII levels, or give them von Willebrand factor concentrate to manage the von Willebrand factor problem. Henoch-Schönlein Purpura is a form of vasculitis that's IgA mediated that typically occurs after a viral infection, typically seen in children that are 2 to 8 years old. They present with a classic triad of palpable purpura, arthritis or arthralgia, and abdominal pain. And just remembering that because this is IgA mediated, it might also be associated with things like IgA nephropathy, so Berger's disease. Diagnosis, do a urinalysis to look for nephritic syndrome and do your regular bloods, but often you might not even do that because there's no formal diagnostic criteria, and you might just give them some pain relief. And that's where they typically get the rash, the palpable purpura on the back of the legs. Haemophilia A is just factor VIII deficiency, excellent, so it's more common in males and leads to secondary hemostatic disorders. You'll get a prolonged ABTT, but often a normal INR because factor VIII is affected, but factor VII is not. And you can give them desmopressin or factor VIII concentrate. Haemophilia B is pretty much the same thing, but this time factor IX levels are affected. If you get a multi-choice question, it's more likely to be, the answer is more likely to be Haemophilia A because that one's way more common, whereas Haemophilia B is a lot rarer. But once again, it's X-linked, very similar presentation. But if you measure their factor IX levels, those will be low rather than factor VIII. And for management, you can give them factor IX concentrate. So this is like a table that kind of summarizes the difference between Haemophilia A, B, and von Willebrand disease. So I guess for exam purposes, you can probably just try and use this table to get the main points to know. TTP is multiple microclots that end up blocking vasculature and consume platelets, and it's mostly seen in young and middle-aged adults. It occurs due to something called ADAMTS13 deficiency. So typically this is actually used to break down von Willebrand factor multimers and prevent hypercoagulation. So if they're low, you actually get an increased clotting tendency. This tends to work primarily in the microvasculars, the smaller vessels. And so you end up forming microclots. And as the red blood cells go past these microclots, they end up lysing due to shear forces. Because you're consuming a lot of these platelets to form microclots, you get bleeding elsewhere and you get consumption of all your platelets. Yeah, so you end up with thrombocytopenia and features of hemolytic anemia because the red blood cells are lysing. So do an FBE, do blood film, and you'll see schistocytes on the blood film, coagulation studies, UEC, hemolytic screen, and definitely look for ADAMTS13 analysis as well. That should be highlighted. Sorry, I don't know why that's not. Cool. So this is what schistocytes would look like. They're just irregular, kind of broken apart red blood cells. Hemolytic uremic syndrome is pretty much similar to a TTP, but this time it's occurring in the kidney, characterized by low platelets, acute kidney injury, and a hemolytic anemia. So what they might have is an E. coli infection, typically one that has the Shiga toxin, and this can then bind to the glomerular endothelium. When it does, it causes immune response and attracts platelets and once again forms microclots. So as the red blood cells go past, they end up lysing and causes a hemolytic anemia. So where they present is through an AKI, and they might have bloody diarrhea preceding this, and the bloody diarrhea is telling you that they could have had an E. coli infection. So you want to do stool MCS and look for the Shiga toxin, but usually these patients are only offered supportive treatment because it kind of self-resolves on its own with time, but you might give them a bit of hemodialysis for acute support. So once again, this is just a picture showing macroangiopathic hemolytic anemia. So that's an umbrella term for things like TTP, HUS, and DIC, where you're forming microclots and the red blood cells are lysing. Cool. So speaking of DIC, this is dysregulated release of plasmin and thrombin that causes intravascular coagulation and bleeding at the same time, typically seen in things like APML, so cancer, which we'll talk about hopefully. So you get increased fibrin degradation products because you're also having increased fibrinolysis. So they're going to present with both features of thrombosis and hemorrhage at the same time. They'll have reduced platelets, reduced fibrinogen, increased PT, increased AVTT, and increased FDP. So pretty much everything's kind of gone out of whack. You want to manage them through emergency management like doctors ABCD, identify and treat the cause. And if they're thrombotic, give them heparin. If they're hemorrhagic, give them your blood products. So once again, a table that summarizes the different bleeding disorders and what you might see in terms of your coagulation studies. Always remember to also rule out iatrogenic causes. So things like if they were given anticoagulation and now they're taking more of it or something's interacted with it. So now their I9 APTT has kind of gone higher, or consider something like liver disease as well. Disorders of hypercoagulability, not really going to talk about this in too much detail. Just know that if it comes up as a question, factor V latent should be the answer, but because it's the most common. But if factor V latent is not available as an option, or they mention that factor V functions normal, then consider protein C deficiency or protein S, so going down. So protein C should be the next top answer, then protein S, and then antiphospholipid syndrome. And that's just going by epi, like which one's more common. And then there's a whole bunch of others, but I really would not recommend going through hypercoagulable disorders. They don't come up very often. Venous thromboembolism can come up, and I'm sure your respiratory lecturer would have covered this, things like VTE, DVT, and PE. No, Virchow's triad, so things that cause hypercoagulation, vascular injury, and circular stasis, all of these increase your tendency of developing clots. And although you don't need to know Wells criteria off by heart, I think it's a good idea to kind of mention it in an OSCE if you do have a kind of thromboembolism station, so that you're thinking about different tools that you can use to identify the risk that this patient has. And then management, so what you give them initially, their long-term management, and how long you might give it for. Make sense? This is stuff you can read in your own time, so I'm not going to sit there and read the slides. Oh, myeloproliferative neoplasms, let's go. Okay, so there's four main types. There's polycythemia rubra vera, which is overproduction of RBCs, essential thrombocytosis, which is overproduction of platelets, and CML, which is overproduction of white blood cells. And then there's myelofibrosis, which is excessive fibroblast activity within the bone marrow. Most of these occur due to a JAK2 mutation, particularly things like polycythemia rubra vera, but some of your ET and MF, so myelofibrosis, can occur due to CALR mutations as well. CML is the odd one out. That occurs due to a Philadelphia chromosome translocation. So this is kind of a summary of all the different neoplasms and what you get. So with PRV, you get erythromelalgia, which is kind of red, hot, itchy, burning hands and legs, and pruritus after a hot shower. They might also have features of gout as well from increased cell turnover, so they have increased uric acid levels. Diagnose them by noting that they have an increased hemoglobin but reduced EPO levels. And you give them venipuncture, so you pretty much make them bleed to treat them. ET can be due to CALR mutations as well, and this is mostly asymptomatic, but you might notice that they have increased platelet levels, and on bone marrow biopsy, increased megakaryocyte count. Give them aspirin because that's an antiplatelet. CML is the Philadelphia chromosome, causes increased infections, B symptoms, bone pain and bleeding, and you'll see increased white blood cells, and you can do cytogenetics to determine the translocation. And you don't need to know too much cancer therapies, but imatinib is probably one I would probably remember for CML because it was mentioned as part of first year content. And then there's myelofibrosis. So that's going to cause pancytopenia because the fibrosis replaces all the normal cells. So they get anemia, B symptoms, joint pain. They might also get bleeding, bruising, and massive splenomegaly that can extend all the way into the right iliac fossa. Leukoerythroblastosis is referring to immature red blood cells or white blood cells within the peripheral blood. And you pretty much treat them with stem cell transplant or hydroxyurea. Once again, this is a summary of what you see. And I've got details on each of these, but I'm not going to run through them. I think the table goes through most of the things you want to know about each of these disorders, but I've got it here in case it wasn't taught properly to you guys. Myelodysplastic syndrome, the only thing I'm going to mention here is a dysplastic or dysfunctional hematopoietic stem cells characterized by three things: megablastoid erythroid precursors, hypersegmented neutrophils, and sideroblasts. So this is what megablastoid erythroid precursor looks like. It's just a massive red blood cell that's nucleated. If we do a bone marrow biopsy, we can see some sideroblasts, so once again, a ring of iron granules. And this is a hyposegmented neutrophil, also called a Pegler-Hewitt anomaly, but that's the same thing as a hyposegmented neutrophil. Make sense? Good. Leukemia, oh, rip. Okay, so leukemia, the main points to know here are that it can be myeloid or lymphoid and divided into acute or chronic. So acute is generally immature myeloid lineage problem. Chronic is a mature myeloid lineage problem. Lymphocytic is the same thing, but it's coming from the lymphoid lineage. Most of the, leukemias are more common in males. And usually if they're acute, they're generally a little bit worse. And chronic forms are more common in older patients. So ALL is the most common pediatric leukemia, but CLL is the most common adult leukemia. AML, remember our rods, and if it's a faggot cell, that's just when there's too many our rods within the cell, and that's typically associated with APML, and they might get DIC as a complication. This one's myeloperoxidase positive. CML is a 922 translocation producing the BCR-ABL fusion gene, and we've talked about this already. ALL, pediatric patients, and they sometimes present with a mediastinal mass. So they might have shortness of breath or cough, and this is TDT positive. CLL, on the other hand, is the kind of indolent tumor that kind of goes in the background that people will often die with but not of, and you treat this with rituximab. Once again, I've got details on each of these that you can review in your own time, but that table is the main stuff you want to know for your exams. Cool, lymphomas. Starting off with lymphomas, you want to divide them into Hodgkin's or non-Hodgkin's and stage them using Ann Arbor staging. Signs and symptoms are pretty much similar for all the different lymphomas. So lymphadenopathy, recurrent infections, hepatosplenomegaly, constitutional symptoms, and you diagnose the type of lymphoma based on biopsy. So I found this diagram useful at kind of making kind of sense of what all the different lymphomas are doing. Pretty much this is showing a B cell in different stages of its development. So this is a mantle cell that then becomes follicular B blast, centroblast, centrocyte, and then a marginal zone. As a general rule, the earlier in the development that the lymphoma occurs, the more likely it is to be aggressive, as a general rule. So mantle cell is often much more aggressive than something like marginal zone. And then there's more diagrams, whichever one, oh, okay. Hopefully this will come up normal in your PDF, but this was another diagram that showed the same kind of info. Once again, this is a summary of all the different lymphomas. The main things I want to point out are that for Hodgkin's, they have painless lymphadenopathy that gets painful after alcohol consumption, and you see Reed-Sternberg cells. And with follicular, it's 14-18 translocation, small lymphocytes, notched nuclei, and they're CD5 negative. DLBCL can pretty much occur as the other lymphomas become more and more dysplastic, and it's a rapidly enlarging lymph node with sheets of large lymphocytes. Mantle cell is going to be positive for cyclin D1, that's its characteristic feature, and marginal zone is typically due to chronic H. pylori infection. CLL is kind of like, SLL is kind of CLL that's kind of gone to the lymph nodes. So it's monomorphic cells that are very small. They might have some para-immunoblasts, and they're similar cells found in the bone marrow. Burkitt's is 8-14 translocation, typically seen in children that have had an EBV infection, and they present with a rapidly enlarging jaw mass, and these are highly aggressive. Starry sky appearance on pathology. Once again, I'm going to skip past most of this stuff. Oh, that's a beautiful Reed-Sternberg cell right there. Okay. And you can review the details in your own time, but once again, the table is the main thing you want to know. Cool. Okay, we get it. Okay, cool. And this is a table that's listing out all the different immunohistochemical stains. The ones I had in the table were the one I memorized, and that helped me differentiate between them. But this is another table, whichever one helps you memorize which type of cancer has which immunohistochemical stain that's positive or negative, that would be helpful. Manoj, I need your help again. All right, pretty much nearing the end of this. So am I meant to finish soon? Yep, cool. Really quickly, plasma cell dyscrasias. So it's a kind of range of disorders. There's monoclonal gammopathy of unknown significance that then turns into smoldering multiple myeloma, which turns into multiple myeloma and then a plasma cell leukemia. The main one you want to know is multiple myeloma because this is the one that we generally try and treat, and this is when the patient becomes symptomatic. This is just another diagram showing what I just mentioned, that it's kind of a spectrum and starts off as MGUS and then goes all the way up to a plasma cell leukemia. So multiple myeloma is uncontrolled proliferation of terminally differentiated plasma cells, and it's due to mutation in cyclin D1, 2, and 3, and they end up producing dysfunctional immunoglobulins. At the same time, they also express rank L, and they end up producing pancytopenia by displacing the other bone marrow cells. As a result of these features, they end up with CRAB symptoms, so hypercalcemia from breakdown from the osteoclast activity, renal failure because the immunoglobulins get stuck within the kind of glomerulus, anemia because they're displacing all the normal bone marrow tissue, and bone pain because they're working in the bone marrow. You might also get amyloidosis, so you want to look for that on pathology, and constitutional symptoms for patients with multiple myeloma might be absent. So they might not actually get fever and weight loss. You want to do urine electrophoresis and look for a Benz-Jones protein, and serum electrophoresis looking for an increase in the immunoglobulins. Cool. So this is what the serum electrophoresis might look like, and notice that the gamma globulins are very high here. So that indicates multiple myeloma. These are the lytic lesions that you might see on X-ray. Once again, this is showing a pathology slide with lytic lesions within the spine due to multiple myeloma. And this is a rouleau formation that's typically seen when there's increased protein within the blood. Oh, sorry, thank you. Increased protein within the serum. So they end up forming this like little chain that's called a rouleau formation. This is showing amyloidosis within the heart. So we can see this kind of apple green birefringence when we use a Congo red stain. So that's all of this amyloid here. And this is once again showing amyloidosis within the vessels. So we can see that this is all amyloid deposition here. Yep, cool. And this is just more proteinaceous material within the ducts of the kidney. So these are all signs of multiple myeloma. And that's what a Benz-Jones protein looks like. Yeah. So I'm not going to go through practice questions because I feel like I'm already running a bit over time. The practice questions are actually a lot more straightforward. They're just taken from previous exams. But thank you so much. And I'm so sorry, there's a lot of content in Haem and Endo, but hopefully that made things a little bit easier or harder, I guess. I'm sorry. But yeah, feel free to message me or ask any questions as well. Thank you. I don't know how to do
practice questions on your post slides.
Yeah, they're going to be.
Okay, I'll upload that.